So what we saw the situs, that's the stomach. This is the heart. We have here quite of a nice four-chamber view, a nice offset of the valves. Look at the atria, especially to the left atrium. There is a strange structure there. And now we go to the three-vessel view. And well, in actual fact, if I count the number of vessels, they are not three, but there is an extra one next to the pulmonary artery. We see the pulmonary artery dividing, and the aorta, the superior vena cava, and then we see another vessel. So what is the diagnosis in this case? Well, I would say that although the heart was normal in the big elements, it may be a variant. So I would say that is abnormal because there was some extra something. And it is indeed a persistent left superior vena cava. And we know that this is characterized by the fact that on the three-vessel view, we will see an extra vessel next to the pulmonary artery. And this vessel is the left superior vena cava that normally is not there. It involutes, but sometimes it persists. And it will drain into the sinus coronarius and through the sinus coronarius reach the right atrium. But because this vessel is not supposed to be there, the sinus coronarius will be dilated. And we will see it as a round structure within the left atrium. In actual fact, is on the roof of the left atrium.
Can I just ask in terms of how, so you see the terminology in the literature with a left SVC and or maybe bilateral SVC. How can we differentiate, and does it actually matter? It doesn't matter to say whether it's bilateral SVC or left SVC in terms of the management or the counseling.
Well, usually is bilateral, but there are also cases where there is only the left and the right is missing. Less common, but there are cases. Well, the management is, let's say, this would be quite of a normal condition also after birth. The only challenge is whether we should offer these patients invasive procedures, especially in view of the risk of a micro deletion, of a 22q11 deletion. And I think that although the risk is not very high, there is a kind of a agreement that we should do an invasive procedure in these cases. At least that's what we do in Amsterdam. I don't know what is your management, Asma.
Obviously, finding something like that, which is often picked up at the 20-week scan, is very, very rare, but sometimes maybe picked up at 12-week scan, but the majority are picked up at 20-week scan. And therefore, we would do detailed testing, a detailed sort of scan. Both, obviously, the heart scan, so that will be an indication for a fetal echo. In the UK, will be by a fetal pediatric cardiologist, for example, and that to rule out any associated cardiac anomalies. And then also by a fetal medicine specialist or someone who's sort of experienced to do detailed ultrasound to look for extra cardiac abnormalities. Because obviously there has been association with other cardiac anomalies or extra cardiac anomalies. But I guess if you have, of course, that means there's a higher risk and certainly would offer invasive testing. I guess if it's isolated, which is a little bit controversial, I think, Katia, and certainly
Controversial,
yeah. And there'll be some that would say, well, I think the risk is very low, and therefore I think it's sort of unlikely. Then you will find the chromosomal abnormalities. The chance is not zero, but and they will be actually say, well, there is still chance of chromosomal abnormalities and offer invasive testing. And then there is sort of another option, a third option, which is offering NRBT or self-free DNA, and the self-free DNA will be there is sort of some companies or so some tests that can actually also do extended or including the George, for example. So that's another option that some people
Yes, that's not the case everywhere in all the countries, and I think that's well, for the Georgia may be quite accurate. Not much for the other microdeletion, but well, I was obviously referring to the case of an isolated left IBC, because obviously it's the first step will be to do a extended echocardiography and then also to check that there are no associated anomalies. So I would say that is abnormal, and then we saw already the diagnosis, and this is the persistent left subclavian artery